Okay, so today we are diving into a topic that's a huge deal for any anesthesiast working in obstetrics, managing pain during a cesarean section. And let's be clear, this isn't just about patient comfort. This is a critical, high-stakes situation that requires a really solid evidence-based game plan. It's a topic you absolutely have to nail for your exams.
And if you're wondering why it's so critical, well, this quote from the 2022 Guidelines in Anesthesia pretty much says it all. We've shifted. This is now the biggest medical legal risk we face in this field. So understanding how to prevent and manage this isn't just good for patient safety, it's absolutely essential for your career.
All right, let's get into it. Here's our clinical playbook for today's explainer. We're going to walk through the whole thing, step by step. We'll start with understanding the risk, then look at prevention, what to do in a crisis, and, super important, the follow-up. Think of this as your structured guide to smashing this topic in an exam.
So first things first, let's really get a handle on the size of this problem. To understand why it's such a medico-legal minefield, you need to know how often it happens and the kind of impact it can have. This context is key before we can even talk about how to prevent it.
The number you'll see quoted for how often this happens is, well, it's all over the place. Somewhere between 5 and a pretty staggering 30%. Now, you might be asking, why the massive range? It really just comes down to how you define pain. Is it needing any extra pain relief, or is it only when you have to convert to a general anesthetic? The main point, and your key takeaway here, is that no matter how you slice it, this is a common problem.
Okay, so let's move on to our first line of defense, setting ourselves up for success from the very beginning. And the first and maybe the most important decision you're going to make is your choice of anesthetic technique.
You've basically got two main options here. You can do a brand new, single-shot spinal, or you can top up an epidural that's already been in place for labor. The spinal? Generally, it's faster and a lot more reliable. But extending an epidural, well, you're working with a catheter that might have been sitting there for hours, and that comes with a much higher risk of a block that's just not complete, or what we often call patchy.
And the numbers, they really make the risk crystal clear. This is from the Kinsella audit back in 2008, a landmark paper you should definitely know. For spinals, they found a 6% failure rate. But just look at epidural extensions, 24%. That's a 4 times higher risk of the patient feeling pain. That is a critical stat to have in your back pocket. This table does a great job of breaking down the key risk factors you need to be watching out for. And notice something? A whole lot of them apply specifically to epidurals. High BMI, needing lots of top-ups in labor, a more urgent procedure. These all wave a red flag for potential failure. For spinals, the big one is a previous C-section, or if a tubal ligation is happening at the same time, probably because the surgery just takes longer. Knowing these flags is step one. So this is the crucial part. You've administered the block, but how do you really know it's working properly? A really thorough multimodal test is just not negotiable, and you've got to follow the protocol to do it right. So what's the target? We're aiming for a block all the way up to the T5 dermatome. Yeah, the skin incision is much lower, down around T10, but the sensation from the uterus and other organs travels much higher up. There was a classic study by Russell back in '95 that showed if you have a solid block to T5 when tested with touch, the patient won't feel pain during the operation. Think of it as your safety margin. The best practice protocol here is a multi-step check. First, start with light touch. If you're even a little bit unsure about the level, you confirm with something else, like cold sensation. And this is a big one. Don't forget the motor block. You have to ask the patient to lift their legs straight up. If they can lift them against gravity, it doesn't matter how high the sensory block seems to be, that block is not dense enough for surgery. How you ask the questions is just as important as what you're testing. You've got to avoid leading questions. So instead of saying something like, "You can't feel that, can you?" you ask a neutral question like, "Tell me what this feels like." This helps you avoid confirmation bias and get a much more accurate picture of how good the block really is. Okay, let's talk about the crisis scenario. Despite all your best efforts, the surgeon makes the incision and the patient reports pain. This is a critical moment, and you need to have a calm, systematic response plan ready to roll. So let's just pose the exam question directly. Picture this. The surgeon is operating, and your patient says, "I can feel that. I'm in pain." What do you do? Right now, your answer needs to be a clear, step-by-step algorithm. Here's your plan.
Step 1, acknowledge the patient and tell the surgeon to stop as long as it's safe to do so. Your patient has to feel heard and believed. Step 2, reassure them and their partner that you're on it and you're going to get the pain under control. Step 3, give some fast-acting IV pain relief. And finally, Step 4, if that pain is still there, you have to reevaluate and be ready to escalate to a general anesthetic.
So what's in your toolkit for this? Small, careful boluses of fast-acting opioids like fentanyl or alfentanil are great, or you can use small doses of ketamine. But here is the absolute crucial point, and it's a classic exam trap. Do not treat pain with sedatives or anxiolytics. Things like benzodiazepines don't treat pain. All they do is risk confusing your assessment and could lead to a really traumatic state of awareness without recall.
At the end of the day, you are the patient's advocate. If you think getting effective pain relief with other methods is unlikely, you should be the one to proactively recommend converting to a general anesthetic. And if the patient themselves asks for it, that request has to be honored if it's at all possible.
So the surgery's over, the baby's out, but your job is not done. The postoperative management of a patient who went through this is so important for their psychological well-being, and yep, it's absolutely an examinable topic.
The experience of feeling pain during what should be one of the happiest moments of your life can have just devastating consequences. And we're not just talking about a bad memory here. We're talking about real, clinically significant psychological harm, including postpartum depression and even PTSD. This is why a structured follow-up isn't just a nice thing to do. It's essential medical care. And here is the protocol you should follow. A senior anesthesist needs to see the patient before they go home from the hospital. And honestly, the most important thing you can do in that meeting is listen. Let them tell their story and validate their experience. Then offer a clear explanation of what happened. After that, you need to document that conversation and send a note to their primary care doctor and their midwife. And finally, you offer them a direct line of support for any future pregnancies.
Whew, okay. We have covered a lot of ground. So what are the absolute key takeaways, the stuff you absolutely must have locked in for your exam? Let's boil it all down.
Here it is, short and sweet. 1. This is the #1 reason for successful litigation in our specialty. 2. Remember the stats? 24% failure rate for epidurals, only 6% for spinals. 3. Your target is T5, and you test it with light touch and a motor check. 4. Your crisis response is stop, reassure, medicate, and escalate. And 5. A formal post-op follow-up isn't just a good idea, it is mandatory. And I'll leave you with a final thought to take into your own practice. Knowing what we know, that extending a labor epidural carries about a 1 in 4 risk of failure, how should that change the way we talk to patients before the procedure? How can we better manage their expectations and, more frankly, discuss the alternatives up front?
And that's a wrap on our explainer. This analysis was based on these key guidelines and reviews. They are absolutely essential reading if you're preparing for your exams. Thanks for joining us.